Hello everyone. Today I'm going to show you about differential analysis of nodular calcification. The key differential analysis issue overlap in a radiographic appearance of calcified collection. Calcification means structure-less density. Ossification of finite density with cortex and trabecular. Maintain high suspicion for malignancy when calcification is present within months. Helpful clue for common diagnosis. Calcific tendinopathy, hydroxyapathic deficit disease, HADD in tendon, shoulder, hip, abductor, most common size, may present with acute symptom pain, fever, mildly elevated white blood cells count. Apparent change over time may completely reabsorb. Calcific bursitis, HADD involving bursa, shoulder and hip most common. Flavolate, small round calcification in vessel, characteristic central lucency, common in pelvic and leg. Pyrophosphate atrophy, calcium pyrophosphate dehydrate, crystal deposit. Chondrocalcinosis in knee, menisci, wrist triangular fibrocartilage complex, additional deposit in capsule, ligament and burst, injection granuloma, classic hotel location, central recency, evasion fractions, early small osseous fragment can mimic ossification. Cartilaginous fragment may calcify. Joint body mimic. Intra-articular feature of ossification. Other location. Bicep tendon seat. Popliteal cyst. Gout. Soft tissue nodule with cloud-like mineralization rather than trans calcification. Calcified tophi, pressure, erosion, and intraosseous collection. First, metatarsopharyngeal joints, Achilles tendon insertion, and olecranon bursa common. Foreign body, history of trauma include extruded PMMA, cement, knee joint replacement, bone graft, adjacent to fracture or surgical sites, apparent change as healing progresses. This is AP radiograph, so several nodular calcification of varying size in the low pelvis. They are typical for platelet. A lucent center is characteristic but not always present. PA view, so extensive amorphous calcification deficit within the corpus include triangular fibrocartilage, scapholunate articulation, and capsular soft tissue. Multiple bones are also evident, finding a typical for calcium pyrophosphate dehydrate deposit. Axilla cone down view demonstrate an amorphous calcification calcium deficits, and the insertions of deltoid tendon. Calcium deficit can affect the tendon and may even erode digestion bone. AP radiographs show nodular calcification deficit located superior to greater diversity, though the deficit looked solid in this radiograph. The distribution became linear on internal rotation, confirming location in the bursa rather than tendon. AP radiographs show several peripheral calcified lesions in the right gluteal region from pre-air injection. The central lucency is common but can also be present in labeling. AP radiographs show a small density along the lateral aspects of the carcinus resulting from evasion of the bifurcation ligament recognition of these subtle injury depend on knowledge of common size for evasion. Correlation with history of trauma and size of pain will be confirmed. On this AP view of the hip, the cluster of amorphous density rejects along the femoral legs. On the lateral view, they were immediately anterior to the femoral legs, confirming intra-articular location. The associated osteoarthritis is a presumptive etiology. AP radiograph of the foot from a patient with severe gout may reveal large tophi in the great toe with cloud-like mineralization, extensive intraosseous mineralization. An uncommon finding is also present. Lateral view show radiodan material within the soft tissue of the tip of this index finger. This patient suffered a pain gun injury in which the patient is possibly driven through the skin. On this postoperative AP radiograph of the tibia and fibula, the tibia bone graft appear as multiple irregular density of varying size. Helpful clue for less common diagnosis. Hyperparathyroidism, renal osseodystrophy, also be multi-lobulated dense collection in peri-articular distribution, wrist, knee, hip, shoulder, elbow. Associated finding superior stereosorption, vascular calcification, and evidence of kidney failure. Myositis ossificans, early amorphous calcification around 1 month after trauma before ossification. Radiolucence is shown between bone and myositis. Unlike malignancy of osseous origin correlate with history of original trauma, although patient may not recall trauma. Follow-up examination established diagnosis as major tuberous architecture, scleroderma, lobulated calcification plus tophi resorption, and most common site in extremity occur along extensor surface. Hematoma occur as peripheral even with history of trauma with follow-up to exclude malignancy unless there is complete lack of enhancement on amide. Meniscus ossicle, knee, posterior horns of meniscus ossification mimic intraarticular body. Dermatomyositis, typical seed-like calcification, occasionally globular inter- and intramuscular calcification, bilateral systemic disease. Mixed connective tissue disease, dermatomyositis and scleroderma finding. Synovial chondromatosis, multiple intraarticular density, range, span, mineralization to classification. Fairly uniform in size as opposed to joint body of ribocytes associated with osteoarthritis. Also may occur in bursa tendency, soft tissue tumor containing nodular calcification, soft tissue hemangioma, mass with fat, vessels, and platelet. Maffucci syndrome and chondromatosis plus hemangiomas. Uterine fibroid calcification in midline pelvis, range from small global to massive calcification tumor. Synovial sarcoma, up to 50% contain dystrophic calcification, usually peripheral. Vast majority are extra-articular. Hemangiopericytoma cannot differentiate from benign hemangioma by imaging alone. Rheumatoid nodule, common over olecranon process and other dorsal surface of upper extremity calcification uncommon. Associated with findings include periarticular erosion, osteopenia, joint space narrowing. AP radiograph of the pelvis show multiple bronchitis and mineralization in a patient with chronic kidney disease like amorphous calcium deficits are present around, around the hip. There are light calcification, uterine fibroid, and severe platelet aspect. Lateral radiograph of the elbow or follow-up of a previous dislocation show amorphous mineralization within the anterior soft tissue. Subsequent image demonstrate evolution into mature osseous of the architecture typical for myositis ossificans. Lateral radiograph of the knee show multiple globular foci of mineralization in the subcutaneous tissue. Psychosis of mineralization can occur along extensive surface of the extremity of patient with scleroderma. Axial non-contrasting NCD so extensive myofascial calcification with focal areas are more confluent nodular calcification. Axial CT so numerous rounded calcification body within the knee joints as well as extension of the collection into the posterior soft tissue of the knee. Lateral radiographs show multiple round calcification associated with a soft tissue mass in the sides. These are platelet within a hemangioma. AP radiographs show a large mass in the pelvis containing nodular calcification. This type of calcification is typical for uterine fibroid, although this is an unusual large example. Close inspection of this lateral radiograph reveals soft tissue mass with several foci of mineralization. The presence of calcification in the mass should raise possibility of malignant, and this proved to be a serious sarcoma. Non-contrasted CT show an anterior compartment mass containing platelet following contrast. The mass inhaled intensely. Vascular tumor rank from benign to malignant, and it is not easy to differentiate them by imaging feature. PA radiographs show a soft tissue nodule with cause scalloping of the underlying bone, though this could present a giant cell tumor of the tendon, seed narrowing of the second metacarpophalangeal joints, and the marginal erosion, suggests rheumatoid arthritis. Helpful tool for rare diagnosis. Hypervitaminosis D from a metastatic calcification with large calcified periarticular masses associated ligaments and intravertebral calcification, then yet fractured bone. Metastatic calcification, large deposit around large joint, disturbance of calcium or phosphorus metabolism can be resolved with treatment. Numerous etiology, chronic kidney disease most common. Systemic lupus erythematosus, area calcification most common in low extremity, joint subluxation without erosion, calcific myonecrosis, amorphous or plaque-like calcification in muscle compartment, usually low extremity, tumoral carcinosis, idiopathic, diagnosis of exclusion with same appearance as metastatic calcification, classic presentation, child or adult of African origin. Trevor Fairbank disease, dysplasia epiphysealis, hemimelica, lobulated intra-articular osteochondroma mimic calcification, base simulated intra-articular body, thermal injury burn, steeple calcification in areas of burn or along contraction band, sarcoidosis like calcified periarticular masses are rare. Ehlers-Danlos syndrome, subcutaneous calcification, control dysplasia constata, Zalvis with congenital steeple epiphysis, pseudo hypoatrophic parathyroidism, calcification, short metatarsal, and metacarpal. Parasites, ribobatitis, cysticercosis, avoid density oriented along axis muscle fiber, myelorheostosis, classic undulating cortical hyperostosis area soft tissue calcification, lipoma with metaplasm, verifying fatty lesion with calcification and trabecular bone. Oblique radiographs show multiple nodular foci of mineralization that have accumulated in the finger. Metastatic calcium deposit occur in numerous conditions in which there is elevated serum calcium. AP views show multiple round foci of mineralization of ribosites around the hip and sides. Subtle collapse of the left femoral head is present secondary to ocular necrosis, though more common in dermatomyositis. This finding may also occur in lupus. CT saw multiple course calcification in the anterior compartment of the legs. Calcification involved the entire length of the muscle, which is also atrophic. The patient reported prior severe trauma, helping establish the diagnosis. AP radiograph, a massive collection of mucous mineralization surround the shoulder. The patient had no known disease. Metabolic workup revealed renal tubular disorder, which led to tumoral carcinosis. Lateral radiographs show lobulated ossification, which is intra-articular and apparently arrived from the major femoral condyle. It is a calcification mimic and present trevo with Fairbanks and intra-articular osteochondroma. AP radiographs show steeper epiphysis along the sacral ala as well as at the proximal femora. Steeper epiphysis on a number of abnormalities in chondrodysplasia constata or Corandi ornament disease. AP radiographs show subtle soft tissue calcification as well as short first metatarsal disease. The combination of finding that make the diagnosis of pseudo hypoparathyroidism. Lateral radiograph show a non-specific rounded calcific density in the subcutaneous tissue. Most parasites monoparasite in the musculoskeletal system do not reduce calcification, but cysticercosis does, with up, oblong right shape calcification more common. AP radiograph of the knee shows small dense pussy within the major femoral condyle and several dense nodule in the soft tissue. This linear distribution of soft tissue and osseous lesion provide a clue to diagnosis of myelorheostosis. Thank you.